Hello everybody, looking forward to give my presentation. So, how do you start with managing of heart failure in pregnancy? It's very complicated because there are many different conditions which can lead to heart failure in pregnancy, and I will come to some of them. But there is actually a position paper which was published in the European Journal of Heart Failure in 2021. And if you have one of the more rarer causes of conditions that can lead to heart failure. Let's say you have a patient who had a heart transplant and wants to plan a pregnancy, or there is a long section on patients who had cancer therapy and want to plan a pregnancy. You find very detailed information in this paper. So how do you start? What's the practical approach to cardiac disease in pregnancy? Present with heart failure. So the patient can have a known pre-existing heart disease as congenital heart disease, aortic valve leaks like Marfan disease, rheumatic heart disease or valve prosthesis. The patient can present newly with a newly diagnosed heart disease unmasked by pregnancy, and this is not rare. So they can have a familial cardiomyopathy. Where I work, we see commonly undiagnosed rheumatic heart disease, where they present for the first time in pregnancy, or undiagnosed congenital heart disease. Then patients can have a newly developed heart disease such as peripartum cardiomyopathy, gestational hypertension, preeclampsia, which can also lead to diastolic heart failure. I think the modified WHO classification is very useful for risk prediction. And why? Because there are 4 groups. WHO 1, where you have minor cardiac disease, like you have an operated atrial septum defect. That's group 1. They have a minimal risk. For group 2, you can see this is unoperated atrial septum defect, repaired tetralogy of Fallot, most arrhythmias, mild left ventricular dysfunction, hypertrophic cardiomyopathy, native or tissue valve, and Marfan syndrome. I think you will speak about that. Yeah, I'm not speaking about it. Repaired coarctation. So the maternal cardiovascular event rate is 5 to 10%. Group 3, this is everyone with mechanical valve, systemic right ventricle, cyanotic heart disease, other complex congenital heart disease, and others. And then you have the patient who have WHO group 4, where pregnancy is considered as contraindicated. And this is anybody with pulmonary arterial hypertension of any causes, severe systemic ventricular dysfunction with an ejection fraction of less than 30%, being symptomatic class 3 or 4, previous peripartum cardiomyopathy with a residual cardiac dysfunction, severe mitral stenosis, severe aortic stenosis, we come to Marfan, and severe aortic coarctation. So how do you start? I think a practical approach is really, if the patient is known to have an underlying cardiac disease, no, then you follow the diagnostic algorithm. Yes, you manage according to underlying disease. Important question is if a patient has comorbidities or any aggravating factors. Then, if the patient is already at first presentation heart failure, this is a really severe, poor prognostic sign. And then it's very important what the week of gestation is. If the patient is less than 16 weeks of pregnancy, it depends on the country, but I mean in South Africa, if the patient is less than 16 weeks of pregnancy and has signs of heart failure, we recommend termination, irrespective of what it is, because it's unlikely that you can go through, let's say, 32 weeks. It is, in our experience, rarely possible. So, and also it's the chance for a reasonable good fetal outcome is very slim. There is growth retardation, they're born prematurely. So we do, that's our recommendation. Already in heart failure is less than 16 weeks, we end usually the pregnancy or encourage. Some women choose not to. If it's more than 60 weeks, so if the patient is 20 weeks you try to get to 28 weeks, and we have to do that very regularly with a number of our patients who only arrive to our service. We have a dedicated cardiac maternal clinic. They only arrive weeks 20, 24. We have to get them to a stage where the fetus has a chance of survival and the mother is still alive. I want to highlight, there are dedicated papers you might know from the ROPAC registries, from the European, from the ESC, European Society of Cardiology. There is, and it's just finished, there was a registry over a period of 15 years, which collected cases from a very large area. There were altogether more than 10,000 cases with pregnancies. And I was fortunate enough that I'm in the steering committee, and I had access to the data of pregnant women with uncorrected congenital heart disease, and we had more than 1,000 cases. So if you ever have a patient who has non-operated whatever, VSD with pulmonary hypertension, and you want to look up the statistics of fetal outcome, maternal outcome, you will find very detailed information on the various defects of unoperated congenital heart disease. I don't think that type of study will ever be repeated again. It's unlikely. But we all see those cases. Same part of the ROPAC registry, there is a dedicated paper on pulmonary hypertension and pregnancy outcome, and there are the various forms of pulmonary hypertension going through pregnancy. So women who have pulmonary artery hypertension have had still a mortality of 50%. So this is really a terrible prognosis, and the patient should not plan to be pregnant, or one should end the pregnancy. But those papers go in very much in detail into the various symptoms, grading of the heart failure, grading of the right ventricular systolic pressure, and in particular, what is often not discussed, the impact on the fetus. And I think that's something which we neglected to do, because if a child is born, let's say 24 weeks with a birth weight of 2,500 grams, statistically this child will have a lower chance for normal brain development. They will have learning deficiency often. They get earlier coronary artery disease later in life. So the concept of being born very prematurely has a severe impact also on the fetus, and I think that needs to be part of the counseling of planning a pregnancy for women who have a severe structural heart disease. I want to show you a paper. It's not published. It's actually a project from, I was president of the World Heart Federation, and under the World Heart Federation there is funding, there is a program, it's called the Emerging Leader Program. It's for emerging leader, young people who want to be leaders, and they come from all around the world, and they can be pharmacists, they can be a cardiologist, physicians, cardiothoracic surgeons, and they form groups, and there is actually funding for a joint research project. It's every year, so the application time is usually like October, and it's a very useful program. You also used to meet, so this year the meeting is in Brazil. So you work over a year together, and then at the end of the year there is a face-to-face meeting, and it's funded, as I said, by the World Heart Federation. So part of this program is that they do a joint research project. So this is a group who was in the program I think 2020, if I'm not wrong, and they decided to do a project of point-of-care NT-proBNP for the screening of pregnancy-related heart failure, the PREC-HF study. So they're all junior people. And you can see here the aim was through the measurement of natriuretic peptides, such as NT-proBNP, has been recommended as a cost-effective screening test for heart failure. The value in predicting underlying structural heart disease, as confirmed later by echo during pregnancy, is unclear. So they wanted to evaluate the accuracy of point of care NT-proBNP to predict echocardiographic evidence of structural heart disease in pregnant women. So we managed to get a donation of the Roche bedside diagnostic test. And so the method was they used consecutive patients with symptoms of heart failure, function class 2 to 4, who underwent echocardiography at Grotesque Hospital, so it's the hospital where I work, between March 21 and March 22, and compared with asymptomatic pregnant women. Then demographic obstetric data were collected, as well as clinical and echocardiographic parameters. Then point of care NT-proBNP was measured. The levels were compared for structural heart disease and functional cardiac impairment on echocardiography. And then the receiver operating characteristics, ROC curve, was used to determine the level of NT-proBNP that would have the best predictive value for structural heart disease. So I was just a senior also helping writing the paper, but not a leader. So we included 121 women with a median age of 31 years, gravity of 3, mostly in their third trimester of pregnancy. And as you can see, that's how they presented: fatigue, dyspnea, palpitation, dizziness. And some from the signs, this is on the right, some had edema, jugular venous pressure, a murmur or crackles. So the NT-proBNP levels of less than 200 had the highest negative predictive value of ruling out structural heart disease. So what it actually means, if you have a patient who presents with shortness of breath to your primary care clinic, secondary care clinic where you don't have an echo, if the bedside NT-proBNP is less than 200, it's very unlikely that you have a heart problem. For a satellite where I work, I can tell you in South Africa we have a population of 55 million and 161 cardiologists. We have very few cardiologists. And the size of South Africa is 5 times the size of Germany. So it's a huge country. So to transfer people to a cardiology center, regularly we see patients who have to travel 500 kilometers. So in our setup, it's very useful to do bedside testing and then only refer patients who, for instance, have a high NT-proBNP. It saves a lot of resources, cost, time, and others. So the finding of the study is that the NT-proBNP testing might be particularly useful as a screening test in settings where pregnant women do not easily have access to echocardiography. I want to say, there are many different forms of heart failure depending on the structural heart disease, and I obviously can't cover all. So I'm using peripartum cardiomyopathy as one example how to manage heart failure in pregnancy. And it is an idiopathic form of a cardiomyopathy. The patient presents with heart failure towards the end of pregnancy or in the months following delivery. No other causes of heart failure found. The diagnosis of exclusion in the left ventricle ejection fraction is usually below 45. So this is according to the position statement from the Heart Failure Association from the European Society of Cardiology. So what we have come up in those position papers, this one is led by Professor Bauer-Sachs, that you risk stratify a patient according to symptoms and signs. Sorry, it doesn't project very clear, so I can just explain to you. So if the patient presents with mild shortness of breath, the ejection fraction is between 30 and 45, the patient has a blood pressure which is more than 100, a heart rate which is less than 100. Those patients can still be managed in the normal, and even in outpatient setting in the normal ward. If you have a patient what we call moderate severe peripartum cardiomyopathy who are in function class in 2 to 3, ejection fraction usually is then 23 to less than 35. Those patients should definitely admitted, get diuretics, need supplementary oxygen, and we start with early beta blocker therapy. And yes, so if you have patients who present, unfortunately that happens in cardiogenic shock, low blood pressure, they need to admit it in ICU. We do have access to obviously inotropes, ECMO, and these are the extreme cases. And we also, they have a high risk of arrhythmia. So like in Professor Bauersack's center in Hanover, they use a live vest to detect early arrhythmia, because we do know from our other studies that 30% of the patient have a sudden cardiac death. So this is, it makes sense in your head to decide in what groups the patient belong. We did a lot of, over the last really 20 years, we did a lot of research in the management of in the pathogenesis. So we know a lot how this disease is developing. We learned a lot about the care of the patient, and we also know about the detrimental effect of prolactin, the 16 kilodalton prolactin, which is produced in those women. And based on all this animal research, cellular research, now proteomic research, which is in press, we know quite well the pathway, and that inhibiting the pathway with bromocriptine has been now confirmed in a number of trials and is recommended in the European guidelines of cardiac disease and pregnancy, but because they are small trial, it's only a 2B recommendation for certain patients, and in particular the patients in the yellow, in the red. So because you balance advantages and disadvantages of the breastfeeding. That's important. This study, which is the lead author is Alex Mebaza, was published in 2022, has nothing to do with pregnancy, but that's what I do. I mean, patients with peripartum cardiomyopathy have a severe prognosis. Mortality is still between 5% and 20%. So I strongly recommend rapid up-titration of beta blocker, ACE inhibitor blocker, so standard medical therapy rapidly after delivery. So we see the patient 2 weeks post-delivery, 4 weeks post-delivery, 6 weeks post-delivery, because it's clear it improves the chance of survival. So if your health system is allowing that, that's what we do. So we translated the finding, which is now in the European guidelines of heart failure already for a long time in patients with PPCM. What is to remember in patients who are in the peripartum period and have signs of heart failure? Peripartum period is a period of where you have an upregulated coagulation profile. That's normal, because if you give birth, you have to stop the bleeding. So you have various cascades of your coagulation pathway are activated, and that leads to women form more easily clots, as you can see on the right. Multiple clots, often not only in the LV, also in the RV, RA. I mean, we have stunning pictures of clots everywhere, but it's very important to remember, because the women get embolism to the arms, strokes, and patients need anticoagulation. And I know the current recommendation is mainly for if you see clots, but I think one would actually need more research if one should not start it earlier. Chronic drug treatment for patients who are in the peripartum period are now postpartum. It's exactly the same like in other forms of heart failure. But what needs to be remembered, there is chronic drug treatment in all heart failure patients who are breastfeeding. Initiation of most heart failure drugs is only recommended in patients who do not breastfeed. This is something which legally you have to explain to the patient, that if you start SGLT2 inhibitor, ARNI, whatever you're starting, you have to advise them that there is a small amount which is given in, obviously, via the breast milk to the child. So, and that's often not done. There are no specific recommendations how long medication on standard heart failure treatment should be continued. So like in peripartum cardiomyopathy, we recommend at least 2 years after the patient has improved the cardiac function. So I want to highlight there are also general factors contributing to increased maternal and fetal risk in pregnant women with heart disease. I mentioned the WHO factors. There are maternal factors like late presentation, pre-existing heart failure, atrial fibrillation, and anemia. And then there are health system factors, unskilled health workers. There are several studies who have confirmed that. A lack of tools to make early diagnosis, inappropriate referral algorithms, and then long distance to appropriate care. There is clearly a correlation from distance to the hospital. Poor maternal socioeconomic factors are age less than 18, age less than 35, poor maternal education, low household income, long distance to appropriate care. So that also has to take into consideration in planning of pregnancy, in managing of pregnancy, and advising about the risk. So in conclusion, women with substantial heart disease and pregnancy is unique. There are good reference paper to look up. Not everyone is familiar with all those conditions, and it's very important to look up. I do that a lot. If I have a patient with long QT planning a pregnancy, I look up what type of long QT and what is there in the literature. It's very important to look up what is published. Often it's only case reports or case series, but still it helps. A multidisciplinary approach including cardiologist, obstetrician, anesthetist, cardiotoxic surgeon if it's valve disease and others should be facilitated, will improve outcome. Effect of mothers and fetus need to be balanced, and understanding the precursors and preventing heart pregnancy will have the highest impact. Thank you.